Welcome, everybody, to Recovery Machine. My name's Nathan, joined, as always, by my co-host and your co-host Corey. How you doing, Corey?
Hey, I'm good, thanks. How are you doing?
Not too bad. What are we doing today, co-host Corey?
As promised, maybe one or two episodes ago, we talked about safe supply a little bit. We got into the conversation just because quite a bit has changed in our province. Things are evolving as we speak, kind of. And we had wanted to do an updated version of where things are at in British Columbia now with safe supply. And you got talking a little bit about it, but we wanted to break it down a little bit further and get into kind of the actual mechanics of it, the actual ground level, what it looks like for individuals receiving it, what it looks like for care providers. Yeah.
Right.
Would you say that's an accurate direction in where we're going to go?
Yeah. I think the way we want to do it here is in three parts. So we're going to give a kind of a broad overview of what it looks like in the province right now. So for people who are unfamiliar with safe supply, what it means as a tactic in this toxic drug crisis, we're going to go through that. And then we're going to discuss some of the concerns that have been raised about the program. And then the last thing we'll do is go over some comments that people commonly you can see online that are fairly common comments about people's concerns there. So we'll do it in a stepwise fashion. Part one, what is safe supply, Corey?
So we're defining safe supply as safe supply aims to provide a safer alternative for individuals who use substances by offering pharmaceutical grade medications as a substitute for illicit drugs. The program recognizes that people who use drugs are at high risk for overdose and other health-related harms due to the unpredictable nature of the illicit drug supply. By providing a regulated and controlled supply of drugs, safe supply aims to reduce the risks associated with drug use and prevent overdoses. Under the Safe Supply program, healthcare providers can prescribe medications such as opioids, and specifically hydromorphone, morphine, diacetylmorphine, heroin, oxycodone, and also stimulants like amphetamines.
That's right. So what we're seeing in BC right now is all those things you've mentioned. So amphetamines, they're talking about, it could be Vyvanse, Adderall, Concerta, methylphenidate, those types of things. That is being given out as safe supply, or you do see people who are on opioid agonist therapy also receiving those medications. The opioids that they're using specifically, it's dilaudid. So we're seeing a lot of dilaudid, and that, of course, is mostly in the generic brands, but there's brand name stuff out there as well. So that's hydromorphone in tablet form. And that is a form that can be crushed. So it can be crushed and snorted. It can be crushed and injected. And the morphine that they've went with and have used for years and years and years for an alternative in the older methadone maintenance style program is Cadian, which is a sustained release morphine prep. So the one that we're seeing a lot of is the 100 milligram capsules. And one of the interesting, or I guess one of the areas of concern or hurdles that they're facing is the fact that because the street drugs are so potent, a lot of these formulations that were made through the normal avenues are not strong enough to match the fentanyl's potency. So you see people taking handfuls of Cadian. It's not uncommon to have somebody taking a tremendous amount of morphine and then also having some sort of a safe supply almost on a as needed throughout the day. That's often the dilaudid form that they get there. There is a heroin injection program that has started again here in Kelowna. I'm sure there's ones down at the coast, but I know Last year, that program did not seem to be accessible. At least I was unaware of it and unable to contact anybody who was aware of it. But I did talk to somebody last week who is enrolled in that program and is fairly happy with it. Seems to be fairly low barrier, low stigma, and seems to be working out well for that individual. And then we also see oxycodone. So that's the stuff that's in OxyContin, usually given out in oxycodone immediate release form. So the Superdol stuff. So those are the products that are being used generally. There's also here in Kelowna, we have patch programs. So you can be enrolled in a program where you receive a certain amount of fentanyl patches. And that means that you come in and a healthcare professional will put those patches on you. And to be in the program, you have to return in 2 or 3 days with those patches still on. The healthcare professional then removes the old patches and replaces them with new patches. If the patches get lost, or if they're seeing the patches, if the patient not come back with patches on too often, then they'll frequently be removed from that program because they are still concerned about diversion. People are still smoking the fentanyl patches and stuff like that. So those are the medications that are being used. Of course, you still have methadone in the various potencies and flavors and varieties. That's still going on.
And what about with stimulants? You had mentioned methylphenidate, Ritalin, Vyvanse. Are we seeing those in the same kind of, I say radical in terms of perception, but in very high doses?
Yeah, radical is a perfect word for it. No, we are not. We're seeing that still very much being. I don't think there's this, to my knowledge, there's no guidelines for trying to match a stimulant on the street's potency with what we've currently got available. Yeah. And I don't think that's actually got anything to do with cost, or because some of those medications are very expensive, but I think it has more to do with they just haven't got to figuring that out yet. I mean, it's pretty complicated. You have a lot of people who have legitimate ADHD issues. So, lots of times those people are self-medicating along with the rest of the addiction problems they have. So I think they're just trying to do their best to still sort of stick to the regular prescribing for that, but they're being fairly open-minded about, giving somebody stimulants while they're on 2 other opiates, whereas, even 5 years ago, 10 years ago, that would have been unheard of, right?
Yeah. It's really interesting because we've had the conversation on this show before about how these things can't be half measures, how a half measure of a safe supply or a half measure of any of the interventions that we've talked about, it still leaves people vulnerable. People will still, if you're in a state of withdrawal and you're getting a subtherapeutic or an inadequate dose of your opioid, you'll be much more inclined to go to the street. Or go to the illicit source. And that is challenging stigma too. Like, even for me, when I have heard recently what some of those doses are, how high those opioid doses are, it's been shocking, and it's made me kind of take a step back and say, well, wait a second, that's a dose that I've never even heard of in my career, like not even remotely what I've heard of in my career. And then I check that and think, well, who am I to say that? That was not, my experience was very different, both in administering medications and in taking medications. Right. I don't know what that person's sort of therapeutic level or therapeutic range is. And so in that, I've had to kind of check my reactions to some of the doses I've heard about recently. Yeah.
Yeah. I've felt the same way. And I've seen that same reaction from other pharmacists and doctors, especially, doctors who are not involved with the program. If they see some of the, like I talk about some of the scripts that are going out, and they look at the numbers and how is that even possible? Like it's not something that we're used to seeing.
Mhm.
And so you really have to think about it for a second. And what it did for me is it really woke me up to the reality of just how potent fentanyl is.
That's exactly right. Yeah. Yeah. And if we were doing this, well, the need to do this wouldn't even be the same if there wasn't fentanyl, if fentanyl wasn't in everything on the street. But if we were just talking about old fashioned heroin, the dosing that we would be talking about would be quite different, wouldn't it?
Oh, it'd be so much easier to handle, so much easier to tackle as a problem in society. This fentanyl it's a beast, a monster, something that is, there is there's no historical precedent for dealing with something like this. So it's challenging in every respect.
Yeah. Yeah. So I'll keep going here.
Keep going, please.
In BC, the prescribed medications are dispensed through participating pharmacies and specialized clinics, ensuring that individuals have access to a safe and regulated supply of drugs. Safe supply programs in British Columbia also incorporate a range of wraparound services to address the underlying issues contributing to substance use and support individuals in their journey toward recovery. Again, whatever that may look like for them. Those services may include a daily point of contact with a healthcare worker or social worker, just someone a trusting ally who understands what's going on with their health. Access to detox and addiction treatment, mental health support, and social services, which I assume would include the ongoing work towards housing in some cases.
Right. It's important to remind people here that what we're talking about in this overview of safe supply is more of an ideal, as in, if this program was in place and ubiquitous throughout the province, anybody could access it, and there was no disparity between rural and urban centers that way, then we would hope to have all these bases covered. This is the idea. Of course, we can talk about where we're actually at with it a little bit later, but I thought it was important to bring up the relevance of having a point of contact for somebody who is in danger of overdose because they're addicted to an opiate like fentanyl. For a lot of people who, I'm thinking of people who may also have mental health issues. They've also got socioeconomic concerns. Maybe they don't have a place to live. For these individuals, they may have comorbid conditions that are also require a lot of care, like diabetes, something like that, right?
Yeah.
So what this program can offer, besides just keeping people alive, is a point of contact in that you're seeing that person usually through a daily dispense. That's where we're at now. So that means that either through a delivery, that means a healthcare professional is going to that person's home or going to find that person wherever they may be on the street, or that person is coming into a clinic or coming into a pharmacy. And that in itself offers a point of contact that can be used by both the healthcare professional and the individual to access services, education. And I thought we'd just go over a few of them. So outreach and engagement is basically, like you said, Corey, an opportunity to build trust. For a lot of people who have, especially mental illness with a concurrent addiction, it is, and I mean, many people, I think, who have had difficult lives or generally suffered for a long time, become extremely distrustful of not just institutions, but authority figures, even doctors. It could be that they've had bad experiences with all sorts of different healthcare professionals. And for those individuals, it takes time to build trust. So having that daily point of contact is an opportunity in itself to say, hey, how are you doing today? I know you were feeling rough yesterday. How's that problem with your stomach that, you went to emergency to check on you're having trouble with your stomach. How's that going? Those little things that can add up over time and build rapport with that person, so that that person knows that they have an ally who is not just out there to treat them like, like either a customer, like some pharmacies might, or just a burden, like maybe some hospital emergency rooms might.
Yeah. And that's what comes to mind for me. Like, in reflecting on my years in the emergency department, it wasn't a particularly welcoming place. And sometimes it was much more explicitly not welcoming. And lots of times trust was broken, or there was a level of suspicion, or if a stay in hospital might mean possessions were taken away, or you'd lose contact with your friends, or with the spot in the shelter that you might have had, and so on. I mean, I think every conceivable thing that you could imagine of how trust could be broken, it has happened. And yeah, and like you said, even if it's just a person who the individual on the end receiving care might say, like, hey, I've got this wound that's really sore that needs to be looked at, or I'm feeling really shaky, and maybe they didn't identify that it was an issue with their blood sugar or something like that. And if there's a healthcare professional that can catch that and prevent it, I think it's also preventing that trip to the ER if it's caught early enough too, right?
That's right. And that's where you would hope to see some of those acute care costs diminished by catching things before they become a crisis. And I also think that social workers have a lot to offer in this respect as well. And that could be because they've got, a similar kind of point of contact or a relationship that's built over time. They can become that person's kind of ally that they could talk to about what they need. What is bothering them? What's the hardest thing they've got going on in their life right now? And is there any way that they can be put in contact with some sort of resource that can help alleviate that? So a needs assessment is another advantage of having that point of contact.
Yeah.
Case management that's a social work thing. That's basically what they're going to do as far as assessing the patient kind of top to bottom, seeing where they are currently, setting a baseline, and then trying to work with that individual to decide what they want to do as far as, are you happy with the way things are going right now? Would you like to, is the goal to stabilize, maybe lower or decrease the amount of chaos in your life? Or is it to actually get on to, maybe you don't even want to be part of the Safe Supply program. Maybe you want to get into the opioid agonist therapy program and try methadone again, and then work on tapering down. Everybody's at a different stage. So needs assessment and case management for some people can look like helping them find a job.
Yeah. Do the words drug seeking, do those even exist within the context of Safe Supply? Like, I think back to the healthcare system that was so suspicious of anyone who needed opioid analgesia or was vocal about that their analgesia was inadequate, was labeled that. So if an individual who's receiving all of these services and coming into a clinic and says, this isn't enough for me, do they risk losing some of these services or losing contact, anything like that?
Not to my knowledge. No. That term, drug-seeking behavior, has been effectively erased from the vocabulary of the physicians who are dealing specifically with Safe Supply. These are physicians who are empathetic, understanding, extremely patient. It takes a certain type of individual to. Every single patient is a complex patient, and lots of physicians, I mean, it's not a position for everybody, I guess we could say.
Sure.
But from what I've seen, the physicians who are kind of leading the charge on Safe Supply, I have not talked to a single person who, I mean, that doesn't mean it's a free for all. There's boundaries, and they're still sticking to, there's still a protocol as far as if you miss a certain number of doses, even on your safe supply, they will remove you from the program until you go back in and get reassessed. I mean, there's only so much they can do they also have to keep safety in mind.
Sure.
That, I mean, if somebody decides they're going to, leave town for 3 days, 4 days, 5 days, the physician has no idea where that person is. There's no record on Pharmanet. They come back and they want the same dose they had before. There's too much of a risk there. And that needs to be handled in a delicate and kind of nuanced way. And I think the physicians are doing a good job of sort of holding the line, providing some boundaries, but at the same time, I'm not seeing a lot of stigma. I'm not seeing a lot of judgment in the respect of how high people's doses are. It's just kind of they're on board with. They understand the problem and they're trying to save their life. That's it.
Yeah. Yeah. I keep going back to the acute care setting just because that's what I know best from my past. And anytime there was a fractured relationship with an individual, anytime an individual was receiving a treatment for an infection or like a non-addiction related condition, like so they were there treating their MRSA wound in their leg, or they were there treating their surgical wound or something like that. Anytime there ended up being a fracture in that relationship, or the person left against medical advice, or disappeared from care altogether, or it turned into a big row with the healthcare team, that was almost exclusively could be boiled down to the system being unable at the time or unwilling to look at their opioid needs or the needs of their addiction. Almost exclusively. Like I can think of sometimes even where a behavior of the individual receiving care was perceived as like devious or like sneaky. Mm-hmm. And oftentimes that was related to them just trying to meet the needs of their addiction in that particular day.
Right.
And they would disappear. They'd leave the hospital for hours, and maybe they'd come back. Maybe they wouldn't. But if they came back, then you're high. You're intoxicated. Well, they weren't going to get it. What did you expect? Where did you think they were going to go?
Yeah. There's definitely a point where you can't keep people in a room and expect them not to have access to their drug of choice. There's a certain level of kind of reliance or connectivity with that substance where, it's got nothing to do with the person's morality or willpower or anything. I mean, they don't have a choice. Many don't have a choice.
When we're in the state of acute withdrawal, right?
Yeah, I mean, come on, of course you're gonna.
Yeah. So I guess I look back and think I can think of so many moments in my memory that were just set up to fail.
Mm-hmm.
That were where failure in that relationship with the individual was doomed because of our inability to ultimately to give them a safe supply while they were receiving treatment. Yeah.
Sad but true. The other point of contact benefit that I think of is harm reduction in the sense of providing, like we talked about, preventative interventions for medical things, but also an opportunity to provide clean needles, devices, sterile wipes, even giving the person something to wash their hands with, or a drink of clean, cold water. All these things kind of, it doesn't seem like much, but I think it's another way to just improve that person's life a little bit, improve their health a little bit, and prevent problems down the line.
Yeah.
There's also, I think, as you're building trust over time, the person that you're interacting with is going to have a dynamic view on their relationship with drugs. So it might be that when they first start the safe supply program, they're working on getting a stable, safe supply so they're not worried about dying or having to do crazy things to get drugs. So once that's accomplished, I think some people will, be happy with that, and they'll live their life as they want to continue to live it. Other people will start asking questions about, possibly getting into detox or doing some sort of a Suboxone induction or working their way towards treatment. I think a lot of people in these programs, from what I'm seeing anyway, go through kind of it's not a fun for the people who are involved in these programs, the Safe Supply program. I haven't seen any individual who I would classify as having a good time. I mean, right. Sometimes they probably feel okay. Sometimes maybe they even feel good. But in general, most of them are not overly pleased with the way their life is going. Mm-hmm. And they are eventually, I think a lot of them are going to at least try to make some sort of change. Not everybody, but, and I want to make sure that people understand that my point of view on that is one of complete and total autonomy. And I believe it's that person's prerogative whether or not they decide to go to detox or treatment or whatever they want to do. But I think having a point of contact on a daily basis really does it. For some people, they just need a person who's somewhat stable to bounce that idea off, every day. Mm-hmm. So it's almost like it's like a journal record that evolves into something,
Yeah.
That's another thing that can be a positive part of Safe Supply and a point of contact. Mental health support. I mean, in an ideal world, I think we would have Safe Supply integrated in a clinic that was constantly reassessing people's mental health needs. I mean, this is not, I think there's many individuals in our province, individual healthcare workers who are doing an excellent job with the resources we have. And they really care and they're really trying, but man, we need more. We need more people. We need more resources. We talked about jobs, this being an opportunity for people to maybe start looking into either getting a different job or getting a job anywhere or going back to school. Opportunities for education that are out there. The person might not have access to, they might not be internet savvy enough to know what's available. And there's lots of programs that can get people started in education towards building a skill set that can be used to get a job later. So there's all those things. There's being an advocate in general for that person, which I think most people involved in the care of people on Safe Supply are advocates in some way, shape, or form. Legal support, I think that's one that people can be directed to whatever resources are available. There's nonprofit organizations, depending on, gender, ethnicity, all sorts of different programs out there for that. And community integration, I think this is maybe about networking and helping people kind of, getting people together who have similar interests and are on the same path as far as what kind of goals they have in mind. Mm-hmm. And then, ultimately just continuous follow-up and aftercare. So in a grand kind of scheme of what Safe Supply could be, that's kind of an overview of what the program is that we've got going on now and what is generally what we hope to achieve with it. And just so people realize it's not just about saving lives. I mean, that's the first part. It's the ultimate harm reduction tactic, but there's many more things that can be rolled into that program.
Yeah. I know that our intention is we're not trying to do a conversation on like Safe Supply versus mandatory treatment and hauling someone away and putting them into a residential treatment program. But when you think about those two side by side, for me, when I think about putting someone into residential treatment, there would be contact with a social worker, and there would be, there might be things with their housing that are looked at and other opportunities there. But in terms of like looking at an individual holistically and doing things that could actually help to decrease their required amount of an opiate, the safe supply thing is much more well-rounded in that respect.
I agree. It provides a platform from which to work.
Right.
You have to take some of the chaos away before you can even hope to stabilize an individual sometimes.
Yeah.
And I mean, when you're flirting with death on a daily basis, it's very difficult to focus on anything else in your life. So
Right.
you can have the best intentions for whatever kind of treatment program you want to set up for people. But if they're busy worrying about staying alive and getting their drug of choice, I think it's going to be kind of a money thrown out the window type situation.
Yeah. And this is not only maintaining the connections that are currently existing for that individual, but it's helping to build new positive connections within their community, within healthcare.
Correct. Yeah. And I think it also works to repair some of those bridges that have been burned over the last, because the backlash from the Purdue fiasco and how all the doctors and physicians were reprimanded and kind of had their triplicate pads taken away. And, so going from that environment to this now, I think does provide an opportunity for a lot of healthcare providers to rethink their stance on drugs in general and the people who use drugs.
Yeah. In our province, at least, when Riverview Hospital closed, like the message that sent about what we care about, how much or how little we care about mental health. I mean, we still, in Vancouver and across the Lower Mainland, we still see the effects of the closure of Riverview Hospital as being like the primary hub of residential and inpatient mental health care. It's just been of such low priority.
Yeah. It's wild.
It is.
Yeah.
It's been of such low priority, yet so many of us complain and criticize and judge and look at crime, look at rates of homelessness, look at all of these things. And we're only now getting to the idea of like a more well-rounded healthcare service.
Yeah. Yeah. Well, I mean, if you don't treat the cause, you're going to have symptoms galore, right? So I think that'll do it for part 1. So for part 2 of our safe supply info piece, we're going to look at what the risks are. What are the perceived risks? What are the risks that people talk about? We've collected a few of them, and we're just going to go through them one by one and let you know what they are so you're aware, and then you can make up your own minds about how you feel about them, and we'll give you our take on them as well.
Cool.
So here's a few of the concerns that have been raised. The first one, perceived normalization of drug use. So some critics argue that providing a safe supply of drugs may normalize and condone substance use, potentially leading to increased drug use in the population. They express concerns that the program sends a message that drug use is acceptable or even encouraged. What do you think about that one, Corey?
Oh, I mean, we've gone around about this one a lot. You can't help but kind of put the safe supply medications up against alcohol, up against tobacco, up against coffee, things like that, where it comes down to so many other factors in an individual's life. We know that now. We know that an individual's life circumstances and environment and privileges and connections and community and life experience impacts how much alcohol they go to the liquor store and buy, whether or not they're able to quit smoking or whether or not they go and pick up smoking again. And somehow there's this conversation that a safe supply of opiates would be any different, or that it would be different for youth. And I mean, in terms of the youth discussion, that's a whole other discussion, really. But I got news for you. It's out there anyway. For anyone who doesn't think that youth are experimenting or experiencing prescription drugs, I mean, come on. I think another misconception about safe supply right now is that you don't need a doctor's participation, that you don't need a prescription, and that somehow it will it will come to a place where you can go in and buy 8 milligram tabs of Dilaudid off the shelf. I think that perception is out there, like that it will get normalized to that extent.
Right. Okay. Yeah. This could be a slippery slope type argument.
Yeah. And I mean, there was the drugstore in Vancouver, drugstore sort of in parentheses. And sadly that the individual who was running that died a couple of weeks ago. But that was an example of a storefront selling a safe supply of prescription drugs or safe supply of illicit drugs as a means of kind of protest and demonstration. It was inadvertently fuel for the fire of doubt and fire of like the naysayers. Again, it was much more means of protest and demonstration than it is what will actually become the reality. I don't foresee that becoming the reality in our province anytime soon.
No, definitely not anytime soon.
Yeah, I think that there's that misunderstanding and fear often about normalization often kind of lead that discussion. And like the worst case scenario of our youth being able to access it so easily. When
Right.
again, another important counter to that is just as simple as, well, in the current conditions of our province, our youth are at risk of dropping dead on the spot because of how pervasive fentanyl is.
Yeah. So you have to, even if you had a concern with this normalization of drugs, you'd have to weigh that against are you willing to take a risk on your teenager dying?
I sure think that has to be part of the discussion. Yeah.
Yeah. What's the next one?
Next one is something that we talked to with Garth Mullins on our last meeting with him, with diversion and misuse of prescribed medications. There are concerns over that the medications provided through Safe Supply may be diverted, meaning passed along to individuals, friends, or fellow residents, or wherever they may be, leading to unintended consequences. Critics worry that prescribed drugs may end up in the hands of individuals who do not meet the criteria, or that the safe supply could then be sold on the illicit market.
Right. So this is a real concern. And like we mentioned before, I think Safe Supply in BC has dramatically decreased the street price of Dilaudid, the tablets.
Yeah.
There's indication that, and for sure, the medications are being shared amongst the community of people who use drugs. I guess the real metric of concern here would be the impact on new users. So this would be something that has to be tracked over time as this program evolves. And if I think we talked about the rates of overdoses resulting in death that have fentanyl involved versus everything else. And right now, basically, from what we know from the coroner's reports, fentanyl is the thing that's killing everyone. So we would have to track hydromorph, we would have to track Cadian, maybe even track patches, anything that's being used as a safe supply or a take-home supply that could be diverted. We would have to then look at stats in new users. And I think probably teenagers would be where you'd really want to look closely. Yeah. If we are seeing all of a sudden, we're seeing teenagers who are using more opiates and using opiates earlier, if we start seeing actual hydromorph overdose deaths, then that would be an issue that would be a huge problem for this program. So this is one of the concerns that I feel has a lot of merit to it, and it's going to have to be monitored very closely.
Listeners might wonder about witnessed ingestion with Safe Supply. We haven't mentioned that yet. Is having clients or individuals take their Safe Supply, is that the practice, or do some individuals, are they able to go home with it?
Currently, we have this kind of weird amalgamation of the old system and the new Safe Supply system. So many people are being treated with some sort of opiate agonist therapy, so Suboxone or methadone. that will be their witness daily dose.
Mm-hmm.
Then they will receive a package of safe supply to take with them. Sometimes the physician wants them to witness, say, 2 out of 8 tabs. So they'll give them 8 tablets of 8 milligram hydromorphone, and they're to witness 2 of those along with their daily witness dose of oat therapy.
Mm-hmm.
So there's some daily witness stuff going on, but it's hard to implement the program correctly without making an allowance for take-home supply. Like you can't. The only other solution for that would be like 24/7 pharmacies that were, just always sitting there waiting to. And I mean, that's an option. There is a, I guess you could say, witness supply for the diacetylmorphine or heroin injection service that we have going here. I mean, that's something that you go in, you're not supervised per se, but you have to take it's like a safe consumption site, really.
Yeah.
So that would prevent diversion in that respect, but I don't know how you get around. There's some logistical problems with keeping the program effective and also, preventing totally abolishing all diversion. That is not realistic. So
I was just going to say, part of what I wonder about with diversion, and we're going to get to it in 2 points here, is access. And is, at least when in talking to Garth Mullins about it in last couple episodes back, he was highlighting that some individuals have access to a safe supply or to a prescription. Other individuals may not have been connected yet. And part of the diversion, part of the sharing that occurs is for individuals who don't yet have that access. Mm-hmm. So I wonder if, as access increases, does diversion go down within a community or within a building or a neighborhood? I just wonder. I don't have any numbers on that or anything, but.
Yeah, no, I don't think anybody does. It's a big question mark. And I think it is surprising, though, to see the decrease in, like, a 10-fold decrease in the street price of Dilaudid. That's encouraging.
Yeah. Totally.
Like, that means that the people who, whatever it is, the 5% of people who need this program that have access to it, for those people in those areas, I mean, they are obviously getting an adequate supply. So that is a sign of mission accomplished in that regard.
Yeah.
And it also must be very frustrating for, people who are dealing illicit drugs in those areas, because for sure that's starting to affect their bottom line. And that's also what we want to see, right?
Yeah. Yeah, definitely. So we'll move on to the next one here, maybe. There's a burden on healthcare resources. The implementation of safe supply requires significant resources, including healthcare professionals to assess and prescribe, pharmacists to dispense the medications, support services to provide wraparound care. Some individuals express concerns that the program may strain healthcare resources and divert attention and funding away from other healthcare settings.
Well, this one is an easy one.
Yeah.
I mean, I really think that the math is fairly clear. What we're trying to do here is this is preventative care in its most basic form. And it absolutely requires less resources to provide safe supply than it does to deal with nonstop overdoses and deaths. Mm-hmm. And that's not even, I mean, that's not factoring in the decrease in petty crime, the resources that you're basically freeing up the police, because so much less crime is occurring because people simply don't have to break the law because they have their supply, so they can, focus on other things. I've seen a few studies, and different numbers in BC have been tossed around between, if you're somebody who's living on the street and relying entirely on government resources, that can cost a taxpayer between $40,000 and $100,000 a year. per individual, depending on the complexity of care required for that individual. But it's the constant ambulance rides, it's the unstable mental health that results in ambulance or police being called when they never should have been called. There's just, I really believe that if a thorough study was done and we had this program implemented at full scale, it would be a wash. Like there would be, it would be dramatically better financially to run this program, even with, like, I have some issues with the medications they've chosen because of the expense. And I think we could do a lot better in that regard. But as far as somebody saying that this is going to draw resources away, no. I do not believe that's the case at all.
No, for sure. The cost, first of all, if an individual even makes it to the hospital with an overdose, which many do not make it to the hospital.
Mm-hmm.
But if you do make it to the hospital, the cost of a hospital bed is a few $1,000s a day in Canada or in BC. The cost of an ICU bed is somewhere between $7,000 and $10,000 a day. It's outrageous. So it's a no-brainer, I think.
Yeah, it's also you're looking at things very small picture-esque, if you will. I mean, remember that the people who are dying in this crisis it's the most productive members of our society. That demographic is the ones that are dying. It's young people who haven't even figured out a direction for their life yet. And it's people who are basically who should be in the most productive years of their life. So if you look at it from an economic point of view, you're damaging your GDP. That's going to have repercussions for, if this keeps up, I don't know what it'll look like in 20 years as far as our workforce is concerned,
Yeah.
So.
And then lastly, I was just going to say quickly, it's just public health. Like, that is what public health should be as one of the branches of our healthcare system. And in reflecting back on what public health looked like maybe 10 years ago, it was so narrow. Public health did so not encompass what the public is. And public health was minimized down to weighing babies and immunizing. And I'm going to probably piss some public health nurses off, some older public health nurses off by saying that, but like, public health needs to look like so much more, and it needs to encompass prevention. That is a part of it, and this is prevention. So I'm happy to see that it's now looking like more of a part of the public health system.
Right. Yeah. Good point. So the next one, limited access and availability. There have been concerns about the limited reach of the Safe Supply program. Critics argue that the program may not be accessible to individuals who use drugs, and that certain populations, such as marginalized communities or rural areas, may have difficulty accessing the services and medications provided. Yeah.
Again, this is, like I was saying, this is potentially what could lead to more diversion. I mean, the question that comes up for me then is, what would access for everyone who needed it look like? And maybe that's a question that comes up. Well, are you going to provide it to everyone who needs it?
Yes.
I mean, what would that number be? And yes, hopefully we do, right? But that's a number that may be daunting to some.
Sure. The number is around 100,000, I believe, in BC.
And if we're going to do this in a just way, this also has to include our northern communities, our remote communities, and getting healthcare workers, getting the team that is required into those areas to effectively implement this. That's going to cost, I guess.
Yeah, it's not an easy thing to do. It's not an easy thing to roll out. I mean, you're doing something that's very progressive, very new. Northern BC is going to be logistically very difficult, but I think the pharmacy model is the easiest, most accessible way to do things, at least to start. I mean, most communities have at least one pharmacy and a small clinic, right? So Yeah, I don't know what that looks like as far as rolling out to people who are very remote and rural, but how many people are individuals who are very isolated from the rest of the population and also have a heavy daily fentanyl use problem? You know, is there that
Yeah.
many individuals like that out there? I don't know, but
Mhm.
I mean, I think we're going to see, depending on what happens with the federal and provincial elections next year, we're
Mhm.
going to see either this program is going to be a kind of glitch in the matrix that just goes away, or it's going to continue to receive funding. And over the next 5 to 10 years, it might get to the point where it's rolled out to its full extent.
Yeah. Yeah.
Then we'll have the information and we'll see what kind of impact it has on the rates of death.
Yeah. Exactly. So the next one I have here is a lack of emphasis on abstinence-based treatment. Some individuals and organizations advocate for an abstinence-based approach to substance use treatment, focusing on complete cessation of drug use. They argue that the Safe Supply program may not adequately prioritize or promote abstinence-based treatment options, which they believe will provide a more effective long-term solution.
Yeah, this one is not even really worth talking about. I mean,
No.
it's these people are completely missing the point.
Yeah.
I don't think an individual who believes this probably doesn't even understand the basics of harm reduction.
Yeah.
Like, again, this is about keeping people alive. If a person is not alive, they can't change their life for the better.
Yeah. Right.
And further to that point, it's not really anyone else's business whether an individual chooses to use alcohol or cigarettes or heroin or methamphetamines. I believe that should be an autonomous decision made by the individual. And as long as they're not causing problems to the rest of society, then that's the way I look at that.
Totally.
Demanding or believing that abstinence is the only way to live and the only effective long-term solution flies in the face of all the evidence that we have. It's antiquated and ridiculous.
Yeah.
We'll leave it at that. Sustainability and scalability. Safe supply programs often operate as pilot projects or in a limited geographic area. Scaling up and sustaining these programs on a larger scale may present challenges, including securing funding, training healthcare providers, and establishing infrastructure to support widespread implementation.
This is kind of goes back to what I was talking about with accessibility, for sure. Mm-hmm. That will be a legitimate challenge in more remote parts of our province. Anyone who knows the map of Canada knows that most of our population is right along the southern border. And there will be challenges as you get more and more remote, but maybe an effort to collect clearer data is important there. As the programs are refined, and like you said, a pharmacy-based approach or a clinic-based approach where it's a one-stop shop, where it's not services that are in different areas. Maybe that's part of it, I think. But that's a hurdle I think that can be overcome with some creativity.
Yeah, innovation and data collection, and then following data to make decisions. That's how you scale up.
Yeah.
So if they do that, then I think it decreases the risk of us overspending, right, as a province, because we may find that maybe we get to 50% and we are having an impact on the amount of people who are dying from tragic overdoses, but we're finding that our results per dollar put into the program has plateaued. So you're going to have to we're going to have to watch that carefully as the program continues to unfold. And I hope they do. I very much hope that data is going to be accessible to the public.
I hope so too. So next one is lack of long-term solutions. Critics argue that while safe supply programs can provide immediate harm reduction benefits, they may not address the root causes of substance use and addiction. Without comprehensive support for addiction treatment, mental health services, and social interventions, Some individuals may continue to rely on the safe supply without addressing the underlying issues contributing to their drug use.
Well, you've got two options here, two big options that you could look at. If you don't provide safe supply for an individual, how much opportunity do they have to address the underlying issues in their life? Very little.
None. Yeah, very little.
Their day is spent desperately seeking out enough money to get enough drugs to not feel like shit. That's their whole day. Wake up to go to bed. That's the whole thing. Also in there is not get beat up, not get robbed, and hopefully somehow have a place that you can sleep with. You don't have to sleep with one eye open.
Yeah.
So there's that, and how much time you've got to focus on improving your life. And then there's having all those other things removed by having safe supply put in your hand at the start of the day. So that problem is solved. I mean, this is what we're trying to accomplish: is alleviate try to break that cycle, give that person some stability, and then possibly, we don't know, but possibly maybe they'll be able to make better decisions regarding their health and their mental health. That's all.
Yeah. And they're actually much more, as you've already outlined, individuals are much more connected to potential solutions, to connections, to resources, to all of the things that they might need, that might be the thing that was missing, that might be the thing that alleviates some of their stressors and some of their hopelessness.
Yeah. Just having a point of contact might be enough.
Yeah.
With no other help included.
Yeah.
Stigmatization and discrimination. Stigmatization and discrimination. Concerns have been raised about the potential for stigmatization and discrimination against individuals who use drugs, particularly if they are publicly known to be part of a safe supply program. This can result in social marginalization, barriers to employment, and negative perceptions that further perpetuate stereotypes and hinder recovery.
Yeah. And the one that comes up for me is parents and the risk that parents who use drugs run. If you go to a doctor and if you need your safe supply, if there's a distrust there, or if there's a lack of understanding or an issue with the relationship with the doctor, you may be concerned about having the Ministry of Children and Families called. There's a wonderful episode that came out last month by Crackdown called The Knock. And for anyone who hasn't listened to it, it highlights what a parent, particularly a mother, going through trying to access a drug supply, access a safe supply, and the risk of having your children taken away from you. And if there's a distrusting relationship there, or if there's a healthcare provider who's got a lot of sort of stigma in their opinions, then that's a very real risk.
Yeah. That I didn't consider that before, but that is going to be a real legal battlefield there.
Yeah.
And I think on the one hand, I want to say, everybody get out there, talk about your drug problems, discuss them openly. And I think this is part of being educated about the reality of drugs, what they really do, what they don't do, the dangers, the benefits that people get caught up in. So there's that side of it. And then, you're going to be dealing with, in some respects, I mean, I don't even know what the legal system looks like that way. It's probably going to depend on, many times, probably it depends on the individual judge and their own personal feelings about drugs and their personal experiences with drugs that could mean the difference between you keeping your children or having your children taken away. Now that's an interesting one.
Yeah. The stigma and stuff that goes with employers, that goes with neighbors. There's so many different avenues with which stigma could be impacted and would impact an individual's life who's receiving a safe supply. But yeah.
Legal and regulatory challenges. Providing a safe supply of drugs raises legal and regulatory considerations. There may be complexities related to prescribing controlled substances, ensuring compliance with existing drug laws, and navigating the regulatory framework surrounding pharmaceutical grade substances.
Yeah, I mean, maybe you could speak more to that one, Nathan, the regulatory framework surrounding pharmaceutical grade substances. What are we up against there?
Well, I mean, this is a real concern. This will be a real problem. There's we've talked about the federal allowance that's making the current safe supply program possible in the first place. We talked a little bit about their decriminalization laws that were changed there. I think if there's a real desire there, and the policymakers are probably going to look at the results. So what Safe Supply needs to do, if it's going to continue and avoid a lot of these, because legal hurdles that could be the thing that just slows it to a halt, right?
Yeah.
So again, this emphasizes the importance of data collection and making that data accessible to policymakers, because I think it's going to be a lot easier for people who are trying to reconcile all these different drug laws if they've got evidence sitting in front of them that suggests that this program is actually improving people's lives, improving communities, decreasing long-term healthcare expenditure, and saving lives.
Yeah.
If all that stuff looks like it's happening and they've got the numbers there, that I think will make things a lot easier for them to expedite these normally very, these could be very slow legal processes. And yeah, I guess time will tell. This could be one of those kind of wild card ones where everything else could be going well, and then it ends up being that the bureaucracy, this province is notorious for red tape. Maybe that could be the thing that slows it down to the point where it never gets up to steam enough to even get the data. You know what I mean?
Mm-hmm, mm-hmm. Another thought that comes to mind is, what would this look like within our prison system? There's currently opiate agonist therapies and treatments in prison system. Methadone is certainly an accepted treatment within prisons. Would Safe Supply potentially be for a period of time? What would that look like? Or will that be a shut door? What will that look like for individuals who have been accessing a safe supply that maybe have to spend time in prison? There are challenges there too, for sure.
Yeah, those are tough questions, and society will react to those questions in a variety of ways.
Absolutely, yeah.
Very complex.
Another one here is a lack of integration with existing healthcare systems. The successful implementation of safe supply programs relies on collaboration and coordination between various healthcare providers, pharmacies, support services. Integration with existing healthcare systems and establishing effective communication channels can be challenging, potentially leading to fragmented care and limited access to comprehensive services. I think we're getting better there.
Yeah, what else is new with our healthcare system, right?
Yeah,
this is an ongoing problem, and surprisingly, for what I'm seeing, the safe supply, at least here in Kelowna, seems to be. I think they're doing a fairly good job of monitoring, taking care of, and keeping track of people who do need extra care. There's pretty substantial communication between not just the doctors, nurses, social workers, but also the people who work in shelters. They're very good. They're working closely with people who are involved in these programs. And I honestly, I think the level of communication right now in this particular program is probably higher, substantially higher than
Yeah.
what you'd expect in the rest of the healthcare field.
Totally, totally. And I also think right now that, and I don't give the healthcare system much credit on our show here, but I do give them credit. In the last number of years, the movement towards primary care clinics has increased, at least in the Lower Mainland here, or in the southern part of our province, where multiple doctors linked up in a clinic with other healthcare professionals, with nurses, with nurse practitioners, where clinics can be more of a one-stop shop, so to speak. And the healthcare system, that partly comes down to resources, and that they've had to pool resources and put things together, but also I think because it has been fractured and there have been disconnects in many ways, that they've realized that. And I think that is changing for the better.
Mm-hmm. Yeah, no, I'm seeing more hybrid models popping up all the time.
Yeah.
Right now, I know of maybe two more hybrid pharmacy clinics that are going up. And we talked about it before, my proposal to the province for a total one-stop shop with full integrated care, and how beneficial that would be. And I've heard that discussed by people who are in the Safe Supply program, and they often say, why can't everything just be in one spot?
Yeah. Yeah.
They're totally right.
Of course.
It makes no sense. Why they have to go over here, then over there? And, I mean, you talk about building these points of care. I mean, that's the ultimate point of care.
Yeah.
You walk in there and every single person is familiar with who you are, where you're at, what your story is, for better or for worse. You get the right people involved in a project like that. And I really think that is the way to implement this most efficiently and in a most integrated nature.
Definitely.
Next one we have potential.
Last one.
Potential unintended consequences. So critics argue that providing a safe supply of drugs may inadvertently create dependency or enable individuals to continue using substances without seeking treatment or pursuing recovery. They raise concerns that the program may inadvertently prolong addiction rather than facilitate a path towards recovery.
To me, like when I hear that, and I've heard that lots of times in the conversations about Safe Supply, like that's actually what has been going on prior to Safe Supply. That was just sort of the state of existence in our province for a very long time. Was that the lack of resources, the lack of housing, the disconnection with some of these services, stigma, all of those things just kept everything as it was. It is not this proposal of Safe Supply is not enabling. In fact, it was everything else that was keeping things exactly the same.
Yeah. And I think there seems to be a perception out there as well that I hear sometimes, that people think that people who need these programs, these Safe Supply programs, are somehow that their life is a party. Like, I've literally heard they think that, oh, why would, I wouldn't, if I had a safe supply, continuous supply of drugs and free everything, why would I do anything different? And I'm like, go take a look at how some of these people are living. Talk to them about what it's like to be addicted to a substance, to such a potent substance that their entire day has to revolve around it. And if you don't get it, you're fucked in a way that most people would never understand. Not even not even 1%. The amount of discomfort and suffering that somebody who's going through withdrawal from a substance like fentanyl it is so far beyond what most people will ever experience in their lives that there's just there's no words to explain it.
Yeah.
So
exactly.
yeah, it's just misinformed. That's all. And it's I've never seen it. I've never witnessed anybody I haven't even seen anybody who appears to be trying to maximize their dose, or break the upper limit of what they're allowed. Even in the heroin injection programs, it just doesn't seem to happen.
Yeah.
They tend to stabilize at a daily dose, and they're super grateful because they don't have to go on the hunt. And now they're like, I mean, it's yeah, I think this is a concern that is just maybe one from not thinking things through,
And it's kind of old fashioned, like the idea that like you said, that it's a party. It might just be that they feel a little bit better.
Yeah.
You know what I mean? Like that,
Yeah.
they're not, no one is partying on these doses, whatever that even means when people say that.
No, when you're at
they
that
might
level,
just feel better.
yeah, there is no party. There's survival and there's feeling okay. That's your two modes.
Right? Mm-hmm. And if you had like these astronomical doses that we're talking about that are in many cases required in a safe supply, if you had all of these other things in place, all of these other privileges that so many people who say that had, those doses wouldn't be the same either. Like all of your life circumstances would be probably different, and therefore your opioid requirement would also be very different.
Yeah, if you required it at all, because many people just don't react
exactly
in a way that's pleasurable to opioids. So
yeah. So
that's that. That's the end of part 2. Hope everybody enjoyed that.
Yeah, likewise. It was, I know, lengthy, but I think it was important to kind of break down the criticisms one by one.
Yeah.
Because you hear in conversation, I've heard so many different variations of criticisms or of opinions that oppose a safe supply. And they're nuanced. It's a very, very nuanced conversation. So we kind of had to do it like that, I think.